We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 169 and Retina Session 21. And today is the International Masterclass with Professor Elliott Sohn from the University of Iowa. And he'll be talking on macular dystrophies, classification, diagnosis, and current management. I request Dr. Maiti to please introduce Professor Elliott Sohn.
Yeah, thank you, Rolika. Good evening to all. Welcome to this 21st session of this iFocus Retina capsule. It's a privilege to introduce our speaker, international speaker, Professor Elliott Sohn. This is from the University of Iowa City. He was the director, a brief introduction of Professor Sohn. He's the director of the Surgical and Medical Retina Fellowship, serves the Association for Research and Vision and Ophthalmology, that's ARVO, as a chair of Retina section of annual meeting program committee and University of Iowa Physician Board as a member at large. He has written a lot of, he has 70 peer-reviewed manuscripts and 10 book chapters, and served as an associate book editor for the AO Basic Technique of Ophthalmic Surgery, 3rd edition, and voted one of the best doctors in America. On the editorial board of Nature Scientific Reports and Asia Pacific Journal of Ophthalmology, and its ongoing reviewer for multiple ophthalmic and scientific journals. We're extremely lucky to have Professor Elliott Sohn. He will be speaking on the macular dystrophy. Professor Sohn, please. You can start your lecture.
Thank you so much for the introduction. It is a pleasure to be with you guys today. I just request that I'm able to share the screen. It says I'm not able to share it at the moment. Great, thank you. Can you guys see this?
Yes, sir.
Okay, wonderful. Well, I want to thank you again for the invitation to speak at this. This is really a privilege to be here with you guys. Obviously not live in person, but live with you guys streaming, and very exciting opportunity for us to talk about macular dystrophies, which is something that's near and dear to my heart. As I'm a clinician scientist in retina, so I see patients with macular dystrophies, but also do research in this area. And at the Institute for Vision Research at the University of Iowa, we are really doing a lot of very interesting and hopefully promising work for the future in trying to cure these disorders. So feel free to stop me anytime if you have any questions. We'll take a couple breaks as well to make sure you guys can have any questions answered. I also would love to have participation from you guys. We have one of our residents and fellows here that we have rounds very frequently. And so kind of used to interaction with trainees. So please feel free to speak up. Okay, so we're going to talk about first what a macular dystrophy is. What do these look like clinically? What might you expect to see on a fundus exam? What are the things you want to ask about when a patient comes in if you're trying to determine if they have a macular dystrophy? A couple important things would be the family history and the age of onset, among other things that we're going to talk about. The phenotype for macular dystrophies can range. So it's important to know kind of what the different presentations can be. And we certainly use all kinds of ancillary testing to help us determine what a patient may have before we do genetic testing. So we might do imaging, which we'll talk about, molecular diagnostic testing, and visual fields. So I want to start with a couple of potential cases here, that one of which is not a macular dystrophy. So I'm going to just go through these, and then I'm going to have you guys, anyone can just kind of pipe in and tell me what you think is not a macular dystrophy. So patient A here is a 33-year-old female who in the macula you could see some changes, some discolorations, and what we would probably call maybe some fleck-like changes, but they look deep to the retina. Patient B is a 5-year-old male who has this kind of atrophic change that looks deep in the center of the macula around the fovea. and it almost looks like kind of a beaten bronze appearance. Now I'm saying these things, and you should also realize that one of these is not a macular dystrophy. So even though I may say some buzzwords, your job is to figure out, tell me which one is not the macular dystrophy. Okay, so C is a 24-year-old male who's got a couple lesions that look deep to the retina. You can see they're underneath the vessels. There's certainly evidence of a vitelliform lesion, an egg yolk-like lesion in the macula, in the fovea, but there's also a couple of these lesions that maybe aren't as circular, superior to the disc. You can see one nasal to the disc as well, and even further superior to that first lesion. Can you guys see my mouse, by the way?
Yeah, we can see that.
Great, thank you. And then patient D is a 42-year-old female who has outside the macula some of these deep chorioretinal spots here, maybe deep retinal spots, kind of whitish yellow, and in the center what looks like kind of a butterfly type lesion that's also in the deep retina, RPE. So can someone tell me which one they think is not a macular dystrophy?
C is not a macular dystrophy.
C is not a macular dystrophy. Okay, so we have a vote for C. Any other votes? Okay, so everyone agrees that it's C. Well, let's go through the cases here. I'm glad we're doing this, and I appreciate you volunteering to speak up. So patient A is actually a patient with Stargardt disease. They have an ABCA4 mutation, so biallelic mutation, and the visual acuity in this patient is 21/25. We're going to the next one that's not a macular dystrophy. It's C. So C is actually multifocal Best's disease. So it kind of looks like Best's disease if it was only this lesion in the macula, but I threw you off with these other lesions here that are not in the fovea. And so this patient does have a BEST1 mutation, and this is a subtype of Best's disease called multifocal Best's disease. Vision's 20/20. Patient D actually has pattern dystrophy. So they have a PRPH2 mutation, also known as RDS, and this is an autosomal dominant mutation. And this patient also has 20/20 vision with what is, as I described, this kind of butterfly pattern in the center of the macula. So the patient, this is a trick question. So the patient who doesn't have a macular dystrophy is actually patient B. So this is a 5-year-old who actually has a PPT1 mutation causing neuronal ceroid lipofuscinosis, so otherwise known as Batten disease. This patient's vision is 21/25. By a couple years after this, the patient's vision is counting fingers. Patient's vision has dropped precipitously and also has neurologic symptoms. So this patient, even though they look like and is kind of in the age range to have Stargardt disease, this is actually Batten disease. I bring this up because it's a kind of mimicker for Stargardt disease early in childhood, but it's something you really do not want to miss because this is a life-threatening disorder. Patient lifespan is somewhere between around 25, 35 years of age. So it's important that you try to identify these kinds of patients when they come in to see you. Okay, so let's talk about what a macular dystrophy is. So if we were just going to describe it, the best way to define it would be a group of heritable disorders that cause funduscopically visible abnormalities in the macula bounded by the temporal vascular arcades. It's a pretty general definition, but more specifically, macular dystrophies are inherited in a Mendelian fashion. So autosomal dominant in the vast majority of the cases, with 1 or 2 being autosomal recessive. Now, there's a couple of disorders that you could throw into the category of macular dystrophy. So maternally inherited diabetes and deafness would be one, but it's not inherited in a Mendelian fashion. It's inherited with mitochondrial DNA. But it certainly looks like a macular dystrophy. So we're going to talk about that a little bit because you may not see that covered in any other lectures. So in general, macular dystrophies have lesions that are visible when the symptoms first occur. Sometimes they happen before. And maybe you may not see too much on the exam. You might have to have some ancillary imaging, some testing to kind of bolster that. Pathology is limited to the eye for the most part. I already gave you an exception. So maternally inherited diabetes and deafness is not limited to the eye. And they are usually seen in patients less than 50 years old. So this is in contrast to something like AMD, which is not inherited in a Mendelian fashion, and certainly is not considered to be a macular dystrophy. So here's a list of macular dystrophies that have the gene names there, as well as a chromosome and the inheritance pattern. As you can see, the inheritance pattern for the vast majority of these is autosomal dominant, except for Stargardt disease. Stargardt disease is autosomal recessive. There's a certain form of Best disease with BEST1 mutation where it is autosomal recessive. We're going to talk about that as well. But the list of these other kinds of macular dystrophies goes on here, most of which we're going to talk about today. Now, there's other things that look like macular dystrophies, but are not. But certainly drugs can cause a bilateral and symmetric appearance in the fundus, and especially the macula, that actually simulate it. So there's a number of medicines on here. All of them can do it. The latest one would be Elmiron, pentosan polysulfate sodium, which is used to treat bladder pain syndrome, interstitial cystitis. So I don't know, I haven't seen really extensive reports of this drug causing macular changes in Asian literature, so I can't speak to that. We have a review that will be coming out shortly in the Asia Pacific Journal of Ophthalmology that talks about that. But if anyone has seen this in Asians, we'll certainly be interested in knowing more about it. You know, hydroxychloroquine is certainly one that can look like a macular dystrophy. You get a bullseye type of changes in the fovea, around the fovea, and that certainly looks a little bit different in Asians than in Caucasians. So there's a couple other things you should think about when you're trying to determine whether they have a macular dystrophy or not. So as I mentioned, AMD, and really anything that causes drusen. As you're going to see, a lot of the patients with macular dystrophies have some drusen in their macula. So anything that causes drusen could potentially be a macular dystrophy. Central serous chorioretinopathy, it is different than a macular dystrophy in that it has no family history and is often bilateral, but not as symmetric. You can get some RPE changes in the other eye. You often do when they have a presenting lesion in one eye, but not as symmetric as macular dystrophies. Type 2 membranous proliferative glomerulonephritis is an important thing to also be aware of, because this causes drusen in young people. And this is also known as dense deposit disease. The reason why you want to recognize this is that you can diagnose it as an ophthalmologist. All you have to do is just get a urinalysis. If you see protein in there, you should really set some alarm bells off and have you send that patient to the primary care physician, potentially a nephrologist, to determine whether they may have type 2 membranous proliferative glomerulonephritis. Angiostreaks, you know, when it has changes that are prominent in the macula, like say due to ABCC6 mutation, it certainly can look like a macular dystrophy as well, but not traditionally put in that category. MacTel type 2 has some features that look like macular dystrophies as well. And some uveitis, posterior uveitis, like punctate interchoroidopathy, multifocal choroiditis, or a couple examples that might look like a macular dystrophy. Okay, so what should you ask about when a patient may have a macular dystrophy? Well, the first thing, you always have to start with the symptoms. So you want to know, when did the symptoms start? What are the symptoms that the patient is experiencing? There may have been a time in the patient's life where they noticed the vision really plummeted, and you want to try to figure out what that age was. Maybe that hasn't happened yet, but you want to kind of try to find out the tempo and the timing for progression of symptoms. You also want to know, is the patient having trouble with activities of daily living? things having to do with work, getting through day to day, driving, these kinds of things. If the symptoms started during childhood, you want to ask about syndromic features. I mentioned Batten disease already as one important example of that. So you also want to ask about history, especially family members. So have any other family members had similar type of symptoms, siblings, parents? And the other important thing to ask about is if anyone has had a dilated eye exam by a knowledgeable physician. So someone has to know what macular dystrophies look like and something's abnormal to be able to diagnose this. And so then the next thing you want to do is really draw an accurate pedigree if you think that they have a macular dystrophy. So refractive error can be a useful thing to know. Patients with Best disease or Best 1 mutation, which encompasses several different subtypes of Best disease, tend to be hyperopic. So you want to take note of that. Most patients, as opposed to patients with Stargardt disease, where a fair number of them will actually have myopia instead. Okay, so let's talk about a case here. This is a patient or a family with suspected Stargardt disease causing mutations in ABCA4. So this is autosomal recessive. So they have to have 2 mutations to cause the disease. And as you can see, patient 2 and 3 are the daughters of a patient who was also affected, patient 1. So let's look at patient number 2 first. And I realize this isn't the most clear in terms of fundus photos, but you can see based on the autofluorescence that there are all of these hyper and hypopigmented spots kind of in the posterior pole in both eyes, and it looks very symmetric. There's also a central scotoma in both eyes on Goldman perimetry. So this corresponds to an OCT here that, as you can kind of faintly see, loss of the outer retina and EZ band here. You can kind of see that, and it looks pretty symmetric in both eyes. So this patient has 2 mutations. You can see the Pro1380 LU and this intronic mutation IVS42. So let's look at the sister of patient number 2. This is patient number 3, who has what looks like a pretty similar appearance. The Goldman visual fields show central scotomas, but then autofluorescence, you can see better than the fundus photos, does show hyper and hypopigmented spots symmetrically kind of peppering the posterior pole. In this case, there is outer retinal atrophy, a little bit more you see in the right eye than the left eye, and certainly compared to her sister, we can see the retinal thinning in the fovea is not as prominent as in the right eye of patient 3 here. Okay, so this patient has the same mutation as her sister. Not surprising because she has got Stargardt disease. But let's look at patient number 1. So this is the mother, and you can even see from the fundus photos here, which aren't too clear, but on the autofluorescence, you can see there's really these widespread areas of consolidated decrease in autofluorescence that seems to be ringing the fovea here. So it looks like the fovea is relatively intact, but there's certainly these big swaths of areas of decreased autofluorescence with some little dots of decreased autofluorescence in the periphery, in the posterior pole. The other thing you'll notice on the fundus photos, as well as the autofluorescence, is the peripapillary sparing, which is a key feature of Stargardt disease. And so you can see that there's not really much involvement around the optic nerve in either eye here, but pretty prominent involvement otherwise. Again, peripapillary sparing, an important thing that you often see with Stargardt disease. This patient also happened to have a choroidal neovascular membrane, which responded well to anti-VEGF therapy. So mom shares a mutation with the kids, the intronic mutation, IVS, but has a different mutation. So how could this be? Well, it's autosomal recessive, so you got to think, well, it should only really happen in 1 generation, traditionally, but this is an unusual case of pseudo-dominant inheritance because if you take the father's blood, he actually has the Pro1380 leucine mutation that was given to both daughters. So both daughters inherited the pathogenic ABCA mutation from the father, and then and then inherited the IVS intronic mutation from the mom. And that's why the kids got it. So the dad doesn't have disease because he only has one mutation. You have to have two mutations, pathogenic mutations in ABCA4 to have the disease. Does that make sense? Does anyone have any questions about that? So usually with recessive disorders, you're only going to see patients in one generation. But in this case, with this patient, the mother, then you really want to have both patients' blood to be able to, and in general, you actually want to do this anyway for autosomal recessive disorders because you want to determine phase confirmation. So you want to determine that the patient indeed inherited one bad mutation from each parent. So that's why we have the blood from the father to be able to do that. So by exam, it certainly looked like Stargardt disease. But when you see the mom, that's when you get confused. So you have to take a good family history, but really your clinical suspicion is very important. And that's what's going to lead you to do genetic testing for the most likely variant first, so that can be confirmed. So my colleague, Ed Stone, looked at 1,000 patients that came in consecutively to our inherited retinal disease clinics over a 5-year period and came up with these estimated frequencies. This is not surprising. These aren't surprising numbers. We know that Stargardt disease is by far the most common macular dystrophy. It's the most common inherited retinal disease of all of them. The frequency is 1 in 10,000, which means that 1 in 100 people carry the mutation, but don't have the disease, of course, because it's recessive. So pattern dystrophy and Best disease, Best macular dystrophy follow in terms of frequency. So they're seen in relative increased frequency compared to some of the other more rare macular dystrophies, but not as frequently as Stargardt disease. And here's a couple other disorders with even less frequency over the 5-year period. So we're going to talk briefly about genetic testing. It's important. This would certainly be a topic for like an hour-long lecture. But the key thing is I want you to be aware of is that you should really offer this to patients when they have findings suggestive of a Mendelian disorder, in this case, a macular dystrophy. You don't really want to get into doing routine genetic testing for complex disorders like age-related mac generation. And you also want to avoid doing testing in asymptomatic minors, so below 18, at least in the US, 18 years old, that have untreatable disorders. So if they have signs or symptoms of a macular dystrophy, then it's certainly reasonable to test them. And if there's a treatment that becomes available, hopefully soon, for one or more of these disorders, that would also potentially be a reason why that might change. But when you're trying to do genetic testing for a patient, you want to try to avoid doing unnecessary parallel testing when possible. If you know the gene that's causing a disorder, like you think the patient really has Best disease, you should test that first. If that's negative, then it's definitely reasonable to look at other genes. That's our approach at the University of Iowa. We think that's the best approach because you may get some noise. You may get some other things that may throw you off that might confuse you. So you do want to try, and if you can, it's also cheaper if you can do allele-specific testing. It's only, for us, $121 to do that, which is relatively inexpensive. Whereas doing an exome or a genome, and then the subsequent analysis of it is pretty extensive. Just about that, do you guys have genetic testing facilities for inherited retinal diseases readily available to you guys in India?
Yeah, we have genetic testing, but it's not very commonly used. Yes, in some cases we do advise genetic testing.
Excellent, excellent.
Especially in the RP patients, also to see the gene line and the therapy for the newer therapy which has come. Sometimes we do advise, but it's not very commonly and routinely practiced.
Okay. Yeah, and it's the kind of thing where you have to know what you're looking for first. You have to recognize it and then perform it. And as you mentioned, there's now a treatment available for a form of RP RP65, at least that was approved in US. So biallelic RP65 mutations causing labor congenital amaurosis, a severe form, childhood onset RP. So certainly reasonable to test those patients. As I mentioned, there's no treatment available yet for macular dystrophies, but having a gene that confirms the diagnosis is important in terms of advising the patient for expectations, counseling, other family members, and peace of mind for some patients as well. Okay, so let's talk about some diagnostic testing that you might use for macular dystrophies. I alluded them already. OCT is certainly very commonly used. I will get that in every patient with inherited retinal dystrophy. Fundus photography is also very useful for monitoring progress. And autofluorescence can often unmask some things that might be difficult to see on fundus exam or fundus photography. So these are the three tests that I get on patients with macular dystrophies that I see on a yearly basis. And that's the general time that I see them, maybe 1 to every 2 years or so. So I'll get these three tests on all patients. So you might get electrodiagnostic testing, probably most useful for Best's disease. There's another disorder or two that I'll talk about where that could be useful as well. But Best's disease is probably the most useful for electrodiagnostic if you have electrooculogram testing available to you. Perimetry can be useful as well. I think for certain kinds, like you have peripheral involvement from a macular dystrophy, like a severe form of Stargardt disease, perimetry is especially useful. I think microperimetry can also be quite useful in these patients for tracking them as well. Okay, so let's talk about a couple pearls for macular dystrophies that I didn't already mention. So one thing you'll notice when you see enough of these patients is that autosomal recessive disease tends to yield worse visual acuity than what the fundus appearance may suggest compared to dominant disease. We've already seen a couple examples of that, where patients with Stargardt disease don't seem to have as prominent of findings, but their vision can be quite bad compared to patients with something like Best's disease or pattern dystrophy, where it looks like there's a lot of abnormalities going on in the back of the eye, but their vision can actually be pretty decent. It's a general rule of thumb. We're going to break these rules many times today, all these pearls and things to think about. I will say that something that is common for all of them is that phenotypic variability is pretty much the norm. So you'll have patients in the same family with a genetic mutation who look quite different. And if you have the same mutation seen in different families, it can also look quite different. So just because a patient has one kind of phenotype and the sibling doesn't, but they have something that looks kind of similar, that doesn't mean you can rule out a macular dystrophy. That's certainly within the realm of possibility. So the three macular dystrophies that look the most alike are Stargardt disease, Best's disease, and pattern dystrophy. They have a lot of phenotypic similarities. They can all have flecks in the macula. They can all have atrophy to varying extent, vitelliform lesions. And you may not think vitelliform lesions would happen as much in Stargardt disease, but remember that vitelliform lesions are comprised of lipofuscin, and these bisretinoid products are distributed throughout the retina. So even though they may not look like kind of an egg yolk lesion in Stargardt disease, you can still get vitelliform type lesions in all three of these disorders. All three of them can also get choroidal neovascularization or subretinal neovascularization, CNV, so they can all get that as well. Definitely family history is very important. I can't stress it enough when you're trying to determine what kind of macular dystrophy a patient might have. And as we've discussed briefly too, Stargardt disease is recessive as opposed to Best's disease and pattern dystrophy, which are both autosomal dominant. So just right there, if you establish the family history before you even examine them, you may have some idea what you might be looking for. Okay, so does anyone have any questions before we move on to some specific cases? Okay, so the chat. here. So let's see if I should answer some of these. How does posterior uveitis picture cause macular changes mimicking macular dystrophies? I didn't show any, so that's a very fair question. But these patients can get some RPE type changes in the posterior pole that kind of look like flecks, may look like drusen or punched out lesions. And so that would be one where you might think they have a macular dystrophy. I'm sorry if someone had another question as well.
No, I was just asking you Sony's question so that you already took.
Okay, great. Thank you. Okay, so let's move on to some cases here. This is a 26-year-old woman who's got a visual acuity of 20/60. Does anyone want to describe this?
Sony, you want to give it a try?
Yes, ma'am. The media is clear with 0.3 cup disc ratio. Macula showing pigmentation and hypopigmented patches involving the posterior pole.
Excellent, yes. So very good observation skills here. So let me go back to this. So yeah, I agree. Disc looks normal, vessels look normal. You know, your attention is certainly drawn to all of these changes in the posterior pole. And the fovea has some, what looks like deep changes, retinal, chorioretinal changes, RPE changes, and then what looks like may even be some drusen here, these tiny little small spots here, dot-like deep lesions. And then surrounding that, there are these changes that we would describe as probably flecks. I've mentioned that word a couple times already, flecks. These are a good example of flecks where you can see they have this kind of 90-degree or maybe 120-degree angle to them, and they tend to be in the posterior pole. So these are some good examples of flecks. I'm going to show you some even better examples of a little bit here. What do you guys think this patient has?
So pattern dystrophy.
Excellent. Yeah, excellent thought. Pattern dystrophy. This looks very much like pattern dystrophy. However, it's Stargardt disease. As I mentioned, they can look similar, but this is actually Stargardt disease. And this doesn't have this kind of beaten bronze appearance in the center of the vision, but this is a pretty typical thing that you might see in a patient with Stargardt disease. And then you can see clearly these flecks surrounding it. So this patient has an ABCA4 mutation. So Stargardt disease is autosomal recessive. You can see here, there's a couple different severity types of ABCA4 mutation. So on the far left, you're going to see the normal fundus. Below that, you're going to see electrophysiological response with the rods and the cones. This is all normal. And then the ABCA4, you can see the flippase in the outer segment disc membrane here present, doing its job perfectly well. However, with Stargardt disease, which is the most mild form of ABCA4 biallelic mutation, you start to see changes like we just saw, some of these flecks, sometimes it's beaten bronze appearance in some of the vision, and then maybe some decrease in some cone response, but really usually not too much here. You start to see some bisretinoid accumulation because you're starting to lose some of your ABCA4 flippase, the ATP binding cassette ATP transporter here. So you're starting to see some evidence of disease here. Now, patients with more severe phenotype of ABCA4 mutation, so even more severe pathogenic mutations for ABCA4, will give a kind of cone rod dystrophy. And here's an example of a patient with the cone rod dystrophy you can see now a definite decrease in the cone response, and now you're starting to see a decrease in the rod response as well, with fewer functioning ABCA4 and more bisretinoid accumulation. So this is kind of in the photoreceptors, outer photoreceptor area. Now there's also the most severe form of ABCA4 mutation, which is caused by two severe mutations in ABCA4, and that would result in retinitis pigmentosa, where you really have a very attenuated rod and cone response. And without much ABCA4, you get a lot of this retinoid accumulation, and that is toxic to the photoreceptors. You don't want to have too much of that. This retinoid lipofuscin accumulates in that outer retina, and if it's not transported through the RPE, then you get accumulation that results in damage to the photoreceptors. So let's talk about a couple different ways that Stargardt disease can present. Here's a 13-year-old female who's 20/40. I just need to move this off my screen. Great. And what you can see is this autofluorescence is not normal. So the autofluorescence, the hypoautofluorescent area is larger than it should be. It's kind of ovoid. And then you see a couple of these small patches of decreased autofluorescence too. The rest of it looks good, but this is a sign that the patient could have Stargardt disease. And then what you can see on her OCT is that she has a loss of the outer retina and certainly a loss of the EZ band here. Hopefully you can appreciate that underneath her fovea. And this is a very deep foveal dip here, much more pronounced than you'd see normally. So this is corresponding to outer retinal atrophy, resulting in her being 20/40. Here's another patient, also with Stargardt disease, but looks quite different than the last one. This is a 25-year-old woman. And what you see here on the fundus exam are these little dots, these white dots in the periphery. Now, they don't look like your traditional flecks that I showed you before, where they're kind of 90 or 120-degree angles between them. These are just these dots that can be termed confetti flecks. And these are a kind of fleck. But the other things that are useful to see for this is on the fluorescein, you can make out this peripapillary sparing much better, where there's not as much involvement. Otherwise, there's a lot of kind of transmission of fluorescein coming through the posterior pole. You can see on the fundus photo too that there's a little peripapillary sparing here as well. Now, we don't do fluorescein angiograms very often. In fact, I mean, I can't remember the last time I did one for a patient, except when you're trying to detect a CNV. And usually even for a CNV or subretinal neovascular membrane, you're going to use an OCT. So we don't do fluoresceins too often. But here's another patient. This dark choroid that you're seeing in this patient, this 9-year-old female with Stargardt disease, is pretty striking here. You know, you can see there's plenty of fluorescein in here. There's even, it's somewhat late because you can see that there's starting to be some staining around the disc. And then of course in the macula, you see this hyperfluorescence centered on the fovea, but a little bit surrounding it as well. But otherwise, the choroid looks pretty dark. And this dark choroid is really due to distribution, widespread distribution of lipofuscin throughout the retina. This patient has pretty poor vision. On exam, if you saw this patient, they would have a kind of atrophic, very beaten bronze appearance to the macula. Okay, so some things to think about with Stargardt disease. A lot of these patients have pretty good peripheral vision after their central vision loss, except if those cases of retinitis pigmentosa as I described. So Fishin showed that at least in young patients, 52% of patients have a visual acuity of at least 20/40 in one eye. But as you get older, by 29 years of age, it drops to 32% have pretty good vision. And then by 39 years of age, 22% have as good a vision. So genetic testing is certainly very useful and important to try to establish the diagnosis of ABCA4 mutation. At least in our lab here, we can now detect both mutations for ABCA4 in 95% of cases. So testing is pretty good now, so it's worth considering doing this. I mentioned getting phase confirmation. The best thing that, and what I mean by that is segregation. We try to make sure that the patient, the proband, has mutations inherited from each parent. You can't have a parent that has 2 mutations and pass it on to a child. So it looks like, so the child would have 2 mutations, but it's all from one, but they're both from one parent. So that wouldn't be necessarily a diagnosis of Stargardt disease. So you want to try to get genetic testing in both parents, especially if you're going to be doing a clinical trial on these patients. So like I said, 95% of patients, we can get the mutation, both mutations for ABCA4. Less than 5% of these phenotypes that look like Stargardt disease are probably going to be from other things like ELOVL4 mutation, PROM1 mutation, pattern dystrophy, and Best disease. So patients with Stargardt disease really will have acceleration of their disease with increased exposure to light. Certainly has been seen in the mouse model, the knockout ABCA4 model, where if you rear them in the dark, they don't tend to have much loss of their outer segments of photoreceptors and have better preservation of vision. So it's a good reason why we don't do as much fluorescein angiography when we see them, because you don't have to subject them to a bunch of flashes as frequently anymore. So you want to recommend that they wear a wide-brimmed hat, sunglasses, especially on bright sunny days, to try to prevent acceleration of the disorder. This Stargardt disease is driven by the visual cycle, and it's really from having too much retinol in the photoreceptor outer segment area. And so what is that? That's vitamin A. So if you have excess vitamin A, that's likely to accelerate the disease as well. So you want to recommend that patients with Stargardt disease don't have as much vitamin A and beta carotene, which is a precursor for vitamin A. Now, the first AREDS vitamin did contain beta carotene, so we didn't recommend that to patients. Okay, so we've got a 50-year-old male here with a visual acuity of 20/30. Does someone want to throw out a diagnosis here?
So best vertiform dystrophy.
Yes, great, excellent. Exactly right. This is a patient with Best disease, and what you can see here is this very well circumscribed vitelliform egg yolk-like lesion, vitelliform meaning egg yolk-like lesion under the retina. And you can see there's vessels coursing on top of it. And if you were examining them with stereopsis, and or you had stereoscopic fundus photos, you'd be able to see that this has some elevation to it. There's actually dome-shaped in the macula. This is due to a BEST1 mutation in autosomal, and it's inherited in an autosomal dominant fashion. Actually, this patient, you can actually see a little bit of lipofuscin just superior to the disc as well. So kind of similar to that multifocal Best disease that we saw in the first images that I showed you. So here's a patient. So this patient has 20/30 vision. So vision's pretty darn good. Doesn't look good in the macula having this egg yolk lesion, but vision's decent. Now here's a 14-year-old with BEST1 mutation as well. This does not look very good. Looks like the vision would be pretty poor, but they're 20/20. What you're seeing here is a pseudohypopion. And so where the vitelliform lesion was this whole area in the fovea. And now some of the lipofuscin has kind of resorbed. And then so that's where you can see the kind of upper half of the fovea better than the lower, where you see this lipofuscin. And it's kind of it's called a pseudohypopion because it looks like a hypopion, but it's in the back of the eye. So here's an older patient, a 47-year-old, also with Best disease, but has poor vision, 2200. And this is because now the lesion has become atrophic. So it's really fully scrambled, if you want to keep using this egg yolk metaphor analogy. And now you can see that there's what looks like geographic atrophy in the fovea. It's these RPE atrophy, as well as some pigment clumps in the center of the macula as well. So another patient with Best disease, but this time we got an OCT. So this is a 15-year-old with 20/40 vision. You can see they have a vitelliform lesion. And in the OCT, you can see this dome-shaped hyperreflective materialus in the subretinal space. Another 15-year-old patient, different patient with BEST1 mutation. This patient has pretty good vision, 20/40, but what's going on here? Now, it doesn't look so much like a vitelliform lesion on the exam. There's really more kind of atrophy, RPE changes, maybe this kind of halo of hyperpigmentation ringing the fovea. That on OCT, it looks like what we call a pillar. So this is underneath the retina, and it's just this pillar is kind of shooting up into the outer retina. with surrounding subretinal fluid. These correspond to a CNV, and potentially regressed CNV or fibrotic CNV. So variable whether they will respond to anti-VEGF at this point. A patient like this, if they presented to me in clinic, I may offer them one injection and see how it changes, but certainly would give kind of a guarded prognosis. Fortunately, the vision is pretty decent in this case, though. CNV, choroidal neovascular membrane, subretinal neovascular membranes are fairly common in patients with Best disease. We'll talk about that more in just a moment. Now, I mentioned there's a way that you can have recessive form of Best disease, and this is one of these patients. Here's an 11-year-old with 2 BEST1 mutations causing autosomal recessive bestrophinopathy. So Vision's 20/20, if you look at the fundus, there is what maybe might be an old previous vitelliform lesion. You might see a little bit of kind of, not a pseudohypopium, but maybe some old deep lipofuscin here. But what's more prominent is a lot of areas of increased lipofuscin accumulation around the macula that's kind of extending out here. This is a pretty typical appearance of a patient with autosomal recessive bestrophinopathy, ARB. And if you had an OCT of this patient, you'd see a kind of shallow subretinal fluid throughout the macula. So recessive form of Best disease. Now, there's another form of Best disease that's quite striking. This patient has autosomal dominant vitreoretinal choroidopathy, also known as ADVERT. Now, this doesn't look like Best disease at all. In fact, it looks more like retinitis pigmentosa, but not really retinitis pigmentosa. This very dense consolidated pigment in some cases in the periphery doesn't really have bone spicules, but this is not something you see with traditional Best disease. In the macula, you don't even see any kind of vitelliform lesion. There's a little hyperpigmented spot here next to some hypopigmented area, but the vision's excellent. This patient has 20/25 vision. The patient does have some vitreous veils, which is a feature of autosomal dominant vitreoretinal choroidopathy as well. But this is due to autosomal dominant BEST1 mutation. So let's talk about some pearls for macular dystrophies, because there's kind of, I've described a couple different subtypes. I've described multifocal Best disease, ADVERT, autosomal recessive bestrophinopathy, as well as just the kind of traditional Best disease that we normally think of. Hyperopia is pretty common in patients with BEST1 mutations, and this is due to shortened axial length. So patients with Best disease look like they have narrow angles. You know, in von Herrick sign, you can see that it looks like there's crowding of the anterior segment. Some of these patients may even look like they're about to go into angle closure. So I've had some patients who come in with a diagnosis of hyperopia and maybe a Best disease lesion, and they've had LPIs. They've already had laser peripheral iridoplasty as prophylaxis for angle closure glaucoma. Hyperopia is very common with any of these BEST1 mutations. So whether it's ARB, ADVERT, multifocal Best disease, or Best disease. Another important thing I haven't mentioned yet is that fundus and OCT can look totally normal in patients with Best disease, in what they might term a pre-vitelliform stage. This is where electrophysiology could be useful, where you have an abnormal EOG, but a normal ERG in quite a few of these patients. And these patients, you can detect this in even normal appearing individuals, where the light peak to dark peak ratio, so-called Arden ratio, is less than 1.5. So this could be a time where EOG and ERG is useful. I will admit, at the University of Iowa, we have such good genetic testing available to us that we don't even get this. We just go straight to genetic testing when we suspect something. And I think, and the reason for that is really, that's going to be confirming anyway of your diagnosis. So whether they have an abnormal EOG with a normal EOG, yes, it's suggestive, highly suggestive of having Best disease, and some may say pathognomonic for it if that happens. but you're still going to want to get the the genetic testing for it. I did mention how CNVs, neovascular membranes, can be seen and typically respond pretty well to anti-VEGF response or to anti-VEGF therapy. Now, some of these patients will have a kind of subretinal fluid as part of their disorder. And when they get a CNV, the subretinal fluid actually regresses. And the patient starts describing a change in their vision, a drop in their visual acuity. But then when you treat them with anti-VEGF, the subretinal fluid actually goes back to what it was before. So this is what I mean by an aberrant looking response to anti-VEGF therapy. So these patients are particularly susceptible to getting CNVs. So just even kind of relatively modest head trauma, eye trauma can cause it. So it's a good idea to recommend that they have protective eyewear at all times, certainly at times of higher risk activities. Okay, so let's look at a patient here, the 61-year-old woman. We're kind of running out of time, so I'm going to just run through these cases. She's got 20/20 vision, and what she has here are these kind of flecks. So you can see some 90-degree angulations, 120-degree kind of type of angulation throughout the posterior pole. This patient has pattern dystrophy. This is autosomal dominant. Here's the patient 20 years earlier. This is, I think, pretty incredible. Here we have all the records of these patients, you know, through like the 50s, 1950s till now. And so we can look up these patients and their fundus footage from decades ago. But when she was 42 years old, she didn't have the flex. She did have a little RPE change, just nasal to the fovea, that would be called dot and halo, as you can see more prominently on the fluorescein angiogram here, where you see this dot and then halo of hyperfluorescence. And sometimes you can see this on the exam too, as a hyperpigmented lesion with kind of a ring of halo around it. So this patient has a kind of reticular subtype of pattern dystrophy. Here's a patient I showed earlier with this pattern of a butterfly subtype of pattern dystrophy with 20/20 vision. Here's another patient with what looks like geographic atrophy, but has been termed central areolar form of pattern dystrophy, but it really does look like GA, well circumscribed, well delineated here in the macula. This patient has good vision, 20/25, just hanging on the OCT to some photoreceptors that are subserving such good vision. But you can see the atrophy on the OCT next to it. So subretinal neovascularization in one series was purported to occur in 50% of patients. I don't think it's that high, at least in our patient population, but you just have to be aware that it can happen and that it does respond well to anti-VEGF therapy. These patients tend to need more light in dim conditions, especially transitioning from a brightly lit area to a dimly lit area. Kind of similar to having a kind of dark adaptation problem that you might see in retinitis pigmentosa. So that's something you can counsel patients on to try to just make sure that they're aware of that and make sure they have a lot of light around to be able to see things when they transition to dark areas. Okay, here's a patient with what has been called Doyne honeycomb retinal dystrophy, also Malatia leventinese. Depending on what part of the world you go to, they'll call it different things. The British will call it Doyne honeycomb dystrophy, and the Swiss will certainly call it Malatia leventinese, because there's a lot of patients, family coming out of the Levantine Valley in Switzerland that have this disorder, or have the disorder. But finding the mutation that causes this, fibulin 3, EFAMP1 is the name of the gene, actually unified these disorders as well as dominant drusen into one disorder, because now we realize that this one mutation has a varying spectrum of phenotype that can happen. And one of the prominent things that can happen is radialized drusen. We're doing a study on this, so we're going to talk more about this in the future. But the drusen here outside the fovea are kind of radiating outward from the fovea, or you could say inward towards the fovea. But it looks like they're kind of splaying out from the fovea. But your attention is really drawn to these unusual appearing drusen, these kind of large, very clumpy drusen in the macula with some RPE hyperpigmentation as well. These patients tend to have actually have drusen abutting the nasal side of the optic nerve. So you can see that right here. And this is a very common feature. 95% of these patients will have drusen touching the nasal side of the optic nerve. These patients develop atrophy as well as neovascular membranes that is responsive to anti-VEGF. So here's a patient with psoas fundus dystrophy due to a TIMP3 mutation. Vision is relatively good, poor, 21, 25. I'm showing you the periphery first because it's interesting how these patients can have some changes out in the periphery and not just in the macula. But the very common feature for these disorders, and they'll often present with bilateral neovascular membranes in the 4th to 5th decade of life. A lot of these patients, because of their peripheral involvement, will have early night blindness. And the histopathologic thing that's important to know for this disorder is that there's thickening of Bruch's membrane. Some patients will just have drusen early in the course of disease. So you need to be aware that that could be fundus dystrophy, but it could be other things as well, like we've talked about. These CNVs do respond to anti-VEGF, but not as much to thermal laser or PDT. Part of that might be having to do with the thickened Bruch's membrane. I'm just showing the periphery. I'm going to show you the macula now, which is quite dramatic. And you can see here that there's all this subretinal hemorrhage as well as exudate just temporal to the fovea here. Okay, so here's a family of patients with North Carolina macular dystrophy. So North Carolina is a state in the US. So I don't know how often you're going to see this, but I figured I'd at least show it to you. This is autosomal dominant. What's interesting here is that the proband, this 12-year-old, has what looks like a horrible fundus. And her vision's not great. It's 2400. She's got this area of this halo of decreased RPE, so RPE atrophy, and a little bit of increased RPE pigmentation as well in some areas. But look at her sister, 2 years older. Certainly doesn't look like that. Here's that phenotypic variability I talked about within families. She's got 20/40 vision, what maybe might even be kind of some exudate and or vitelliform type of material, some drusen here. Let's look at the mom. The 31-year-old mother basically just looks like she has drusen. You could say these might be some kind of deep atrophic type of changes, maybe even vitelliform type of change in the superior part of the macula, but these just look like drusen. And they kind of look like that on the OCT as well. So this is a developmental abnormality, so it's really present at birth, does not tend to progress over time. So PROM1 associated macular dystrophy, PROM1 is the name of the gene, tends to look like Stargardt disease, but it's dominant, autosomal dominant. This mutation, the ARG373 cis variant, is highly penetrant, and that's what this patient has. These patients tend to present a little bit later than patients with Stargardt disease. Usually Stargardt disease is before the age of 20. These patients have presentation a little bit later than that. And this patient, of course, is older than that. So that's why they have more severe disease. A lot of these patients will have a bullseye maculopathy. So if you see a bullseye maculopathy, this should definitely be on your differential. I'm not showing that here. I'm showing you here central geographic atrophy, which some patients have, and a minority of patients will have some multifocal GA that's not involved in the fovea. Some of the things that distinguish it from Stargardt disease is the fact that they don't have as many flecks. You don't see it as frequently as in Stargardt disease, and you might see some more mid-peripheral nummular bone speculum-like changes in this disorder. Okay, so I mentioned maternally inherited diabetes and deafness. So this is breaking all the rules for macular dystrophy because it's not inherited in Mendelian fashion. These patients have diabetes as well, and they have sensorineural hearing loss in the vast majority of patients. This is due to a to G transition in the 3243 position, nucleotide position in mitochondrial DNA. It's thought that up to 1% of patients with diabetes have MID, which is really high. That'd be like 3 million patients potentially in the world. So something just to be aware of if they have hearing loss and diabetes and some of these kind of changes, atrophic changes, as you can see here, these wide swaths of RPE loss and autofluorescence, something to think about. Autofluorescence can be very helpful in these cases, but you can see even without the autofluorescence on the fundus photos, pretty prominent changes in the back of the eye, suggestive of RPE atrophy that you can see so well on autofluorescence. So I'm going to close the last case going to Asia. This is actually called macular dystrophy, also known as Miyake disease. So it's seen sporadically, but it can also be due to an autosomal dominant mutation in the RP1L1 gene. This fundus in this 36-year-old male looks really good. It looks normal. Looks normal to me. Has poor vision though. Autofluorescence looks pretty normal. This is a pretty normal autofluorescence with this decreased autofluorescence right in the center from the retinal pigment that's blocking. But the fundus photo autofluorescence look pretty good, but the vision is down. So these patients will often get sent to neuro-ophthalmology and they're like, well, the optic nerve looks normal. So what is it? It doesn't look like it's macula. Then they send them to you, the retina specialist, and you're like, okay, yeah, optic nerve does look normal. But when you get the OCT, you may not even see this on all the scans, just a few scans though. There's a little disruption of the EZ band here that you can see. And this is what's typical, this little EZ band disruption and loss on the OCT. Median age of onset is around 30 years old, but vision can go down quite a bit and stabilizes around 2200. So the last thing I want to do is plug our Stone rounds here. My colleague Ed Stone is an incredible inherited retinal disease specialist who's now offering all of his knowledge in a bi-weekly educational rounds that's available to anyone in the public. Well, really trainees, it's an educational thing on Thursdays. I think it's every other Thursday. So if you're interested in learning more about inherited retinal diseases, you can go to the website stonerounds.org. There's various things you can do. You can do modules where you learn inherited retinal diseases. You can see an atlas of patients with their mutations listed and the fundus photos listed as well. So very useful website. And then you can see that there's a Stone Rounds schedule on the bottom as well. That's useful. So then you can know when that's going to be done because that's done over Zoom and has been very well received. So with that, I want to thank you guys for your attention and happy to take any questions here.
Thank you so much, sir. Thank you so much for a lovely lecture, and you've made everything pretty easy for us to understand. I'm sure that these dystrophies have not been easy at all for us during post-graduation days. I wish we had a lecture like this to make it so easy. Dr. Dinesh sir and Dr. Maiti sir, would you like to have any discussion?
I think it's one of the most wonderful lectures I've heard. Very practical, just right level of complexity for the postgraduates. And I think it's something I was really happy to be part of this today. There's only one question I have for you, especially since you do a lot of genetic testing and practically speaking, how much of a difference would it make if I did not do any genetics testing? I just presumed based on clinical checkup that this is a hereditary disorder and treated the lesions as they appeared. When the CNVM comes, I treat the CNVM. The general restrictions that I need to give regarding light, I give them as they are. Would it make a substantial difference to the overall treatment that I do for my patients?
I think that's an excellent question. So what's the role of genetic testing for these patients? And, I think that's probably debatable. We have the service available because Ed developed the testing facility here and everything. So for us, it's very easy to get, but I fully understand and appreciate that in other parts of the country or the world that's not readily available. And I didn't mention a point regarding that. And the fact is that since there's no treatment available that like gene therapy or corrective treatment for the underlying genetic disorder, you could argue maybe it's not necessary to do. So what are some reasons why you might do it? Well, I think if you suspect something and the patient, let's say that the parents of a child with Stargardt disease is thinking about whether they want to have another child, Not to say that they're not going to do it if one child has stargardt heart disease, but it's something useful to know. Let's say there's a family that has autosomal dominant radial drusen, Doyne honeycomb retinal dystrophy, where it's autosomal dominant. If they know that they have a disorder, they can counsel their kids better about whether they need to have eye exams, but also what things to look for if they might develop like a CNV. I think practically speaking, Dr. Talwar, you're very right in that if they have a CNV, you're just going to treat them. You're going to use anti-VEGF. So that's not going to change. But in some cases, you don't know if they have Stargardt disease or Best disease or pattern dystrophy. So are you going to really recommend avoidance of light and vitamin A supplementation as much in patients with Best disease and pattern dystrophy? No, you wouldn't. But that's not necessarily the only reason to get genetic testing. Some patients really want to know for their families, as well as you would like to know as a physician. So I think we are all living in a world that doesn't have the same resources, and it's not fair. But certainly the recognition that these patients, basically with almost any of these disorders, can get a CNV that can be treated with anti-VEGF is a very important key take-home point, whether you know their genetics or not.
Thank you. One more point I'd like to ask you, like you said, avoid carotene and vitamin A, but the newer AREDS formulations with lutein, that's not a contraindication, isn't it?
Excellent point. Yeah, so I didn't mention that, but the AREDS 2 vitamin, you're absolutely right, does not have beta carotene. So I guess the point I'd make about that would be, some patients might take multivitamins thinking that's going to help them. And I wouldn't necessarily recommend that for a patient if they have Stargardt disease, because multivitamins will often have vitamin A and or beta carotene.
And so as long as they avoid beta carotene and vitamin A, you're fine with it. And secondly,
Yes.
One more point I'd like to ask you. In some of these macular dystrophies, orange tinted glasses are often recommended. Do you ever recommend? And patients do say they see more sharper with it.
Yeah, I think that is an area, I've noticed it too. Some patients do describe that. I also have some patients who don't have macular dystrophies who describe seeing sharper vision with these other tinted glasses. So I think it's a very fair point though. Our job is really to try to relieve the suffering of the patient, to figure out what allows them to see the best. And so if some tinted lenses help them, by all means, I think that's a very useful thing to provide additional contrast for them to see. So yeah, that's a very good point.
Thank you. I'll hand it over to Dr. Maiti, who's actually supervising the session.
Thank you, sir.
Thank you so much.
Dr. Sohn, thanks for this excellent presentation. I just want to ask you regarding the investigation. Many a times, as macular dystrophy is missed in a full-field ERG. Is multifocal ERG a better tool to detect the abnormality, especially this macular dystrophies?
I think in some cases it is, in the same way that you might say that microperimetry might be better to follow some of these patients compared to perimetry, kind of similar vein. It's interesting now that we've gotten so good with OCT, and now we're learning more about OCTA as well. But OCT gives you just such good anatomy, and there's so much research now surrounding. We know what a lot of disorders look like just based on OCT. So I think multifocal ERG is certainly a useful thing as an adjunct for diagnostic testing for these patients. But it's not something that you're often going to use to make the diagnosis of a patient. Ultimately, that's going to come from your exam, your diagnostic skills, and take into account their family history and age of onset and that kind of thing. So I think there's certainly some utility as adjunctive information from multifocal ERG. That can in some cases provide more than a full field ERG.
Right. As you are associated with a lot of trials, So is there any hope for this macular dystrophy or anything coming up recently for this treatment, or some trial giving promising results?
There's always hope. We have to hope. So there's definitely hope. We're doing a lot of the work ourselves here to try to develop gene therapies to treat these disorders, as well as there's many other institutions as well as corporations who are developing different kinds of treatments that are in development or trial, and some who have also been pulled from trials. So currently there is not anything that's FDA approved for any of the macular dystrophies. You would think that Stargardt disease would be the thing that you want to treat first because it's the most common inherited retinal disease. However, it's a difficult thing to treat because the gene is large. So the ABCA4 gene is beyond the packaging capacity for AAVs. So you have to use other strategies to be able to try to deliver this gene if you're talking about gene therapy. But there's some other trials out there like deuterated vitamin A, some other things that may have some problems as well. But again, these need to be done in kind of larger trials, and we need to see the safety of these patients as well.
Do we have any questions, Dr. Rolika?
We do, sir, and I would like your permission if I can take those, as the time is already beyond.
Yeah, you can.
I'll take one or two questions.
Yeah.
Okay. So there's a question that what features will be seen if a person has macular dystrophy and added drug toxicity?
Yeah, well, that's a good question. It depends on the dystrophy and the drug. But in general, if a patient has a macular dystrophy, you should be careful about using any of these drugs that I mentioned, or age-related macular degeneration. For that reason, is that it's hard to track whether you might be seeing progression from the disease itself or from the drug. So, anyone with any of these macular dystrophies or AMD, I basically really try to get them off of any of the drugs that mimic macular dystrophies.
Right, sir. So another question, and the last question, but one of the most common doubts that postgraduates have is that how are flex different from drusen's? Like some of them get confused in noticing those. So would you like to highlight that?
Yeah, good question. So the flex look different. So they're kind of in a similar area, as in they're in the back of the eye, so subretinal, around the RPE. So the location is similar to drusen, but the appearance is different. So while they both look kind of yellowish white, drusen tend to be circular lesions, deposits, whereas flex are not really circular. They have a little bit more shape to them. They kind of, it's like they've got like arms or legs to them. So I think that's probably the best way to describe is kind of the shape of and the size of them as well.
I think it's flex or something like this, or like this, or like this, drusen around. So you have a better idea of, so shape-wise, I think that's probably the best way to describe it. So, and I think you showed that in the beginning.
Yes.
Arms of the arms, or the, some are Y, some are right angled, like, L's. So it's, whereas drusen are very clear cut round lesions.
Right, sir. Thank you so much, sir, for the lecture. I really thank you for taking out your precious time for us and teaching the postgraduates a very important topic. Thank you, Dr. Talwar, sir, Dr. Maiti, sir, for the discussion and for sparing your time for the session.
Thank you.
I really enjoyed it, you guys. Thank you so much.
And thank you, Dr. Elliott. I think that was wonderful. And I think that was just the kind of way I would like a lecture to be held in this series of classes.
An interactive case presentation,
Absolutely
which
tuned
is
for the postgraduates, the right questions with the right answers, the right level of complexity for them. Thank you very much once again.
Thank you for your kind words, and thank you for the invitation. It's really a privilege to be with you guys. I hope to meet you in person. So if we're at a meeting or something, please, I hope we can interact there. Looking forward to it.
We hope this Omicron will go soon enough to allow that.
Agreed. Agreed.
Yeah. Thank you so much, sir. Thank you, everyone. Next, we will be having the next session will be on January 14th. That is hereditary choroidal diseases. It's an international masterclass with Professor Sandeep Grover. So we'll see you all there. Have a very good night.
Thank
Thank you.